MedCram.com.
Welcome to another MedCram video. We're going to talk about low carbohydrate diets and some long-term data that's recently come out that's very interesting and I haven't heard a lot of news about, but I want to talk about it. So low-carb diets started out back in the 1950s as a possible treatment for childhood epilepsy and has been looked at extensively for its short-term benefits on weight loss and in a number of other things which we'll talk about. You can see here on the right a breakdown of the three types you can eat. There are carbohydrates, proteins, fats, and oils. So those are the three types of things that you can eat. And this graph is trying to show the different types of diets. There's the typical American diet, which you can see is pretty large in carbohydrates. There's the Atkins diet, the induction phase, which has a very small amount of carbohydrates and a similar amount of protein, but a lot more fats. Classic ketogenic diet, which is 4-to-1, 4 grams of fat to 1 gram of protein. And then there's the medium-chain triglyceride ketogenic diet, which you can see here, where the majority of the calories are coming actually from medium-chain oils. So the first thing I want to say about this is I think this is an oversimplification. We're going to find that out very quickly here when we actually look at this in detail, because if we just look at carbohydrates, for instance, the carbohydrates that come from processed foods, refined sugars, have an effect on the body that's completely different than the same amount of complex carbohydrates, which would come, for instance, from fruit. Fruit is complexed with polyphenols and all sorts of things, and I can show you data, maybe in another video, that shows, for instance, that carbohydrates from fruit juices has a completely different effect on the human body than carbohydrates from fruits. And you can see clearly that it's almost identical in terms of the sum of the parts, but completely different effect on the human body. So let's just start off by saying that this may not be an adequate representation of what we're going to talk about today. Nevertheless, there is a huge move to look at low carbohydrate diets. And the question is what's the evidence for this, especially in the long term? So there was a paper that was published about 10 years ago in 2013 titled Low Carbohydrate Diets and All-Cause Mortality, a systematic review and meta-analysis of observational studies. So let's read what they say here, because I think this is interesting. This was known 10 years ago. A growing body of evidence has suggested that low carbohydrate diets and their combination with high protein diets are effective in weight loss. And there's some references here. And by the way, if you go to this address, you will actually get to see this article and look up those references. And we'll put a link in the description below. They say, in addition, they reportedly ameliorate the risk factors of cardiovascular disease in the short term. And there's some papers there which support that. And of course, that would decrease, you would think, incident cardiovascular disease and mortality. However, recent cohort studies, and again, this is 10 years ago, recent cohort studies did not support this hypothesis. And there's a number of references there that also back up that assertion. And their long-term, that's the key word here, is long-term health benefit and risk remain controversial. In fact, low-carbohydrate diet tend to result in reduced intake of fiber and fruits and increased intake of protein from animal sources, cholesterol, and saturated fat, all of which are risk factors for mortality and cardiovascular disease. There are some that believe that this is all a farce, that cholesterol and saturated fat do not in any way increase cardiovascular disease. There's actually really good evidence for that. And I'm not here to talk about statins or whether they work or not. That's beyond the scope of this talk. But there is evidence that cholesterol and saturated fat is tied to that. Nevertheless, we're going to take a look at this. And so what they looked at in this particular article 10 years ago was to look at a meta-analysis. And so what they did was they took a number of studies that looked at diets with low carbohydrate scores. That's there in A. And also a low carbohydrate to protein score. So low carbohydrate, high protein score. And what they did was they looked at cardiovascular risk and risk of death. When you look at these, you can see here that they're all on the right side of that line. And so when you put them all together, what you get is an increased risk, not a decreased risk, but an increased risk of all-cause mortality with these low carbohydrate diets. Same thing here, as you can see, with these low carbohydrate to high protein scores. So the conclusion of this paper, which looked at observational data, this is not a randomized controlled trial, this is observational data, so there are potential confounders here. They say that low carbohydrate diets were, and the word here is associated, with a significantly higher risk of all-cause mortality, and they were not significantly associated with a risk of cardiovascular disease mortality and incidence. However, this analysis is based on limited observational studies and large-scale trials on the complex interactions between low carbohydrate diets and long-term outcomes are needed. So that's where we were 10 years ago. They said, hey, we're seeing a signal here. It's an associative study. It's observational. And so we really can't make a causality, but we need to follow up on this because if this is the case, we ought to know about it. The point of bringing that up is to realize that you are never going to be able to do a randomized, placebo-controlled trial on low-carbohydrate diet. Number one, the person doing it would know they're on the low-carbohydrate diet. That's number one. Number two, you're never going to be able to just randomly assign people in large enough studies for long periods of time, 20, 30 years, which is what it takes to figure out whether or not you've got coronary disease and death. You're never going to be able to do that. So what's the best practical type of evidence that we can do in epidemiology and in medicine and in nutrition to find out whether or not this is the case? This is exactly the question that we had with smoking and with asbestos and with these other exposures was how do we show without doing a randomized controlled trial that smoking causes lung cancer? How do we do a randomized controlled trial that shows that asbestos causes mesothelioma? You can't do that. And so what you do is the next best thing, which is to do a dose-response relationship in epidemiological studies. So if you can show prospectively in a cohort of people that are not randomized, unfortunately, and are not blinded, that increased exposure to a risk causes an increased determinant of an outcome, then that dose-response curve is highly suggestive of causation. And that's exactly how we made this connection with smoking and with these other toxic chemicals where you cannot do ethically and practically randomized controlled trials. So I show you this article here from the Royal Society that's talking exactly about this. And this was published back in the 1980s. They say this paper discusses dose-response relations by using information about carcinogens in man as examples. So they look at, for instance, tobacco. They look at alcohol drinks, certain drugs, things of that nature, and even asbestos. This is the way that you can, in large-scale studies, show that if there's a dose-response curve, that is highly suggestive of causation. If it's not there, it doesn't rule it out because there's some exposures that don't have a dose-response curve. Like if you're exposed to it, it causes the same problem than if you're exposed to twice as much of it. But if there is a dose-response curve, that's highly suggestive of causation. Now, the reason why I bring that up is because of this abstract that is on its way to publication and also its sister publication, which I'll show you as well. This was published at American Heart, which is a meeting, and this was actually a memorial lecture, so it actually given quite a lot of exposure at the meeting. And they looked at a very large cohort called the Nurses' Health Study, the Nurses' Health Study 2, and the Health Professionals Follow-Up Study. So this is 203,000 men and women in this cohort, so pretty large. And they looked at individuals in this cohort from over 30 years ago. This was just published recently here in 2022. So more than 30 years ago, they looked at people that did not have diabetes, did not have cardiovascular disease, did not have cancer at baseline. And they followed them for 30 years. And they asked them very specific questions about what they ate. Every once in a while, they checked in with them, I think it was every 4 years, about what kind of dietary intake they were taking. As you can see here, 4 years. And they divided them into quintiles or into fifths. So let's pick a topic here. Let's say it's low carbohydrate diets. And they came up with a score about how intense they were on this low carbohydrate diet. And so those in the first fifth, the ones that were the weakest in terms of low carbohydrate diets, were given a reference number of 1. And then they said, well, if we go to the second quintile, how much more likely are they to get diabetes? Now let's look at the third quintile, and then the fourth quintile, and the fifth. In other words, they're looking at doses. As the dose goes up of whatever it is you're talking about, in this case, a low carbohydrate diet, does the risk of diabetes go up? That's the question that they're asking. What they're trying to do is apply a dose-response curve methodology to a very large epidemiological study. And so they looked at over 5 million person years at follow-up. what they found was that there were 20,000 cases approximately of type 2 diabetes that were documented. So they wanted to know, how did those 20,000 cases of diabetes fall out with all of these people? What were the risk factors that caused these people to get diabetes? The results were people who had higher overall low carbohydrate diet scores. In other words, the people that were the most intense on low carbohydrate diets actually had the highest risk of type 2 diabetes. And again, this was in a dose response manner. So we can talk about all of the confounders. This is not just association now. This is a prospective observational study. And yes, generally speaking, that can be plagued with confounders. By the way, they did actually control for those confounders, but you can still have problems with confounders. The issue here, though, is that they did a dose response curve and they found that it was actually there. So this is the same type of evidence that we would look at smoking and lung cancer and asbestos and mesothelioma. So let's take a look at the data. They had 5 different types of dietary patterns. First of all, they had an overall low carbohydrate diet score. And you can see here the case person, year, and the denominator, how many we're talking about. So lives, basically. You can actually look at the raw data if you like. And then there was a multivariate adjustment. And the multivariate adjustment adjusted for age, ethnicity, smoking status, BMI, alcohol, multivitamin use, physical activity, total energy intake, family history of diabetes, hormone replacement therapy, and oral contraceptives. So all of that was adjusted for with a multivariate analysis. And we see here in quintile number 1, that was given the reference. So the question is as we go up from here in terms of the intensity of low carbohydrate diet score, what happens to the odds ratio of developing type 2 diabetes in 30 years? And what you can see here is that the low carbohydrate score went up 7% in the second quintile, 12% in the third quintile, 20% in the fourth quintile, and 28% in the fifth quintile, the most extreme. And that trend was statistically significant. Then they looked at the sub-fractions of this. They looked at an animal-based LCD score. This is an LCD, or a low-carbohydrate diet, which primarily gets its protein and fats from animals. Here we have quintile number 1. This is the reference. As we go up to 2, 11%, 17%, 26%, and a 35% increase in getting type 2 diabetes in a population that doesn't have type 2 diabetes. I'm going to jump down here a little bit because they did a second analysis called the unhealthy LCD score. What is the unhealthy LCD score diet? It's simply the animal-based LCD score, plus they added one other thing to it. They de-emphasized whole grain. So these are people who would have low-carb diet, primarily based from animal sources, and then they would also avoid whole grains, things of that nature. What they found there is that it was even worse than the reference here. Instead of an 11%, it was 17%, 23%, 35%, up to 39% increased risk for diabetes over 30 years in this cohort. As you can see here, it was a dose response curve, and it was statistically significant. So then they looked at another one. They said, what happens if we have a low-carb diet, but instead of getting our proteins and fats from animals, we get it from vegetables? And that was the vegetable-based LCD score. Here we have the reference again. Instead of going up, there actually was a 4% reduction, a 7% reduction, and a 6% reduction across the board in the chances of getting type 2 diabetes. That was also statistically significant in terms of that trend going down. Then they did one other thing. They called this one the healthy LCD score because instead of just doing vegetable proteins and vegetable fats in the low carbohydrate diet, they also de-emphasized refined carbohydrates. So what are refined carbohydrates? That would be like soda, candies, ice cream, all these sorts of things, right? So refined carbohydrates, these are carbohydrates that are not coming from fruit. These are carbohydrates that are coming from refined sugars. Notice here that when you eliminate those refined carbohydrates and also get your proteins and fats from a vegetable source, instead of a 4% reduction, you get a 6% reduction. Here you get a 14% reduction, 10% reduction, and even up to a 15% reduction. So you can see here that not all low carbohydrate diets are the same. You could be on a low carbohydrate diet. And if you're getting the majority of your calories from animal sources, according to this study, and you're also cutting out whole grains, then you can see here that you could be up to 39% increased risk for diabetes, as opposed to vegetable-based fats and proteins and cutting out refined carbohydrates and be at a 15% reduction. So that's 39 plus 15. That is a 54% difference in the incidence of diabetes, depending on the type of low carbohydrate diet that you're on. I want to show it to you a little differently here. This is not time on the x-axis. This is dose. Here we are in the quintile 1 for all of these different categories. And as you can see here, as the dose goes up in each one of these categories, the splay gets bigger and bigger. That's what it is that I'm talking about. As you do that diet to more magnitude, that is going to either increase or decrease your risk of getting diabetes over 30 years. That's just talking about the incidence of diabetes. Let's talk about mortality. This was a paper that was published just this year, February 14, in Diabetes Care, but this is coming from the American Heart as well, and the same group, actually. And it's called Low Carbohydrate Diet Scores and Mortality Among Adults with Incident Type 2 Diabetes. So now we're looking at those people who already have diabetes, and we're asking them, are they going on a low carbohydrate diet? So in this case, we're looking at 10,000 people already with type 2 diabetes, contributing to 139,000 person years for follow-up. They documented about 4,500 deaths, of which 1,300 cases were attributed to cardiovascular disease and 881 to cancer. And again, this is coming from the Nurses' Health Study, the Health Professionals Follow-Up Study, and overall a low carbohydrate diet score was calculated, so the same way that we talked about before, based on a percentage of energy as total carbohydrates. They also looked at a vegetable low carbohydrate diet score, an animal low carbohydrate diet score, a healthy low carbohydrate diet score, and an unhealthy low carbohydrate diet score. And these were further divided. Healthy and unhealthy were divided into those things that we talked about, which was the different macronutrients. So whether or not there was refined carbohydrates and whether or not there was whole grains. We're not looking at the chances of having diabetes, we're looking at the chances of mortality. These are pooled hazard ratios of all-cause mortality per 10 points. So in other words, as the points go up, what direction are we going in? This is that dose-response curve that we talked about. Low carbohydrate diet scores among people with type 2 diabetes. So these are not people without diabetes getting diabetes. These are people with diabetes dying or not dying. And again, we have our same cohort here as well. Notice that the total low carbohydrate diet score in this case actually had a hazard ratio of less than 1. So there was an improvement in survival if you had a low carbohydrate diet in general. But let's splay it out and actually take a look at this. Not a bad idea to have low carbohydrate, not knocking it as well, but it may matter how you make up that low carbohydrate diet. The animal low carbohydrate diet score actually had its 95% confidence interval on the hazard ratio of 1, meaning that statistically it actually made no difference at all. Whereas the vegetable low carbohydrate diet score was at 0.76, which means that there was a 24% reduction in mortality in these patients. Similarly, if we go to the healthy, which eliminates the refined sugars, really not much of a difference. It looks about the same. And if we looked at the unhealthy, getting rid of whole grains, you can see there was actually an increase in the mortality in this case. This was people who had type 2 diabetes. This is the same scores here from those who went from pre to post diabetes diagnosis. And you can see here that it's essentially exactly the same. So I thought this was really interesting in terms of this topic because a lot of people talk about low carb. And when you look at what it is they're eating, there's not a lot of discussion about where those proteins and fats are actually coming from. And as I was saying before, there is a huge difference, not only in terms of carbohydrates, proteins, and fats, but there is a huge difference between the types of carbohydrates. Not all carbohydrates are the same. There's a big difference between complex carbohydrates, which comes from fruit, and fruit, of course, has polyphenols in it, which are antioxidants. and very important in terms of overall health. So there's a lot more going on than just the amount of protein, just the amount of fat, just the amount of carbohydrates. I think that's really important to understand. And one of the studies that actually was very instrumental in teaching me that was this study of over 500,000 titled Fresh Fruit Consumption in Relation to Incident Diabetes and Diabetic Vascular Complications, a 7-year prospective study of 500,000 Chinese adults. And again, if we're looking at how often they get diabetes and how often they die, what you'll see is that as the amount of fruit consumption per month goes up, the hazard ratio drops below 1.0. And you actually have a reduction in diabetes the more fruit that you eat. And why would that be? It seems as though people think that if you eat fruit, you're going to have higher blood sugar values, and higher blood sugar values automatically translate into diabetes. That's not the case. Blood sugar is a surrogate for hemoglobin A1C, which is a surrogate for diabetes control. There is much more going on in your body than just blood sugar. We can become fixated on that number, but realize that when you have whole fruits, whole grains, there are things that are packaged in those fruits and grains which are actually beneficial. And when we eliminate those out of our diet, there is a detriment to that. So we can see here, even with all-cause mortality, not just cardiovascular, but all-cause mortality, that as usual fruit consumption per month goes up, all-cause mortality goes down. So the question of what are in these products that may be helping us, and it seems as though every study that I look at, whether it is epidemiological or interventional or randomized controlled trial, there seems to be a difference between the sources of where we get these carbohydrates, proteins, and fats. This is not the first time that we've talked about this. We talked about this in our video on meat, dairy, and disease, and a new paradigm which is coming forth, which is that of sialic acids. So in the sialic acid hypothesis, which has been the subject of many studies, there is a specific sialic acid in red meat, and this is regardless of how you cook it, how you raise it, how you feed it. This is part of the genetics, called nu-5-GC. So nu-5-GC is a sialic acid in every animal that has red meat, so any mammal, with a few exceptions. And one notable exception is human beings. So human beings do not make nu-5-GC. However, when human beings eat animals with nu-5-GC in it, that nu-5-GC as a foreign substance is incorporated in our cells. It passes our GI tract, goes into our bloodstream, and the enzymes in our body which put sialic acids on the surface of cells do not recognize it as foreign, they recognize it as the same, therefore they incorporate it into our cells. Unfortunately, our immune system does recognize it as foreign, and so literally that expression, you are what you eat, actually becomes true. And in this study, which we reviewed in this article, in men and women both, what they did was they broke them up not into quintiles, but into quartiles. And they found that nu-5-GC in those people that had the least amount of nu-5-GC as an oral intake had the least amount of nu-5-GC autoantibodies. And as the amount of nu-5-GC went up in terms of oral ingestion, the amount of nu-5-GC antibodies went up. And this is causing a low-grade inflammatory reaction. This also happened with women as well. As you can see, there was an increase in nu-5 autoantibodies. And the authors of this study concluded, looking at this and others, that this was a potential mechanism for the explanation as to why we see more vascular inflammation in people who have red meat. And it may also explain why we see the findings that we just showed you here in these studies that were published in 2022 and 2023. The heart is a very interesting organ, and it is susceptible to getting coronary artery disease. And for those of you who are interested in learning more about that, I will recommend coming to medcram.com for our very popular EKG course. You can learn how to read an EKG with this course that offers 10 hours of CME credits. So I hope this lecture was helpful to you. I would highly recommend reviewing your diets and making adjustments as necessary. Or if you have different thoughts, please leave those in the comments below. Give us a thumbs up, subscribe, and visit us at medcram.com. Thanks for joining us.